Dear Chairman, ladies and gentlemen, let me present or continue with FAR NHL Registry of Chronic Heart Failure, and I will focus on arteriuretic peptides and comorbidities in this chronic heart failure. As we know, heart failure is a very common comorbidity, and the natriuretic peptide describe heart failure and can diagnose heart failure, and their serum levels, when they are higher, then the heart failure is more severe and as well could be the worst prognosis. There are many causes of elevated natriuretic peptides, and it could be cardiovascular and non-cardiovascular. And for example, it is atrial fibrillation, as you can see from ESC guidelines, or elderly or kidney disease, but as well acute coronary syndrome, or maybe heart contusion, stroke, ischemic or hemorrhage, or COPD, anemia. As it was mentioned before, the FAR NHL registry contains 1,088 patients. It is a registry of chronic heart failure with at least 1 month stable, patients with left ventricle ejection fraction below 50%, and we included outpatient and inpatient patients, but these hospitalized patients were not hospitalized for decompensated heart failure. The inclusion was from 2014 till December 2015, and it all happens in 3 centers in Czech Republic, and it was St. Anne's University Hospital in Brno, then the other university hospital in Brno, and in Prague, Na Homolce Hospital. Then there participated some institutes from Masaryk University, like biostatistics, pathological physiology, or biochemistry. Let's move to FAR NHL and description of the sample of patients. We can see 80% of patients were male, and median of age was 65 years, and almost 2/3 or 60% were in NIHA class 2, 1/4 was NIHA class 3. The etiology of heart failure was in 50% ischemic heart disease and 43% dilated cardiomyopathy. This slide, or these graphs, I've borrowed from Professor Špinar and his article, and we can see the higher NT-proBNP is, the more higher occurrence of combined endpoints is present. Combined endpoint was death, heart transplant, or implantation of left ventricle assist device. And we can see in the other graph proportion of patients and levels of NT-proBNP, and the black curve means probability of endpoint, and you can see the higher NT-proBNP is, the probability of endpoint is very much higher. Then we have done univariant linear regression to predict NT-proBNP, and as well from this table you can see the higher NT-proBNP was predicted by presence of diastolic dysfunction, atrial fibrillation, diabetes mellitus, higher heart rate or higher age. On the other hand, the lower NT-proBNP was predicted by higher ejection fraction, higher systolic blood pressure, higher hemoglobin level or glomerular filtration rate, or higher body mass index. There was no influence of sex, hypertension, dyslipidemia, or in medical history. Then we have done multivariant linear regression using backwards stepwise algorithm of independent predictors of NT-proBNP, and we can see again higher NT-proBNP was predicted by presence of diastolic dysfunction, atrial fibrillation, higher heart rate, but no longer by presence of diabetes mellitus. The lower NT-proBNP was predicted by higher ejection fraction and higher systolic blood pressure, higher hemoglobin level, or higher glomerular filtration rate, or higher body mass index. So let me conclude this presentation. According to FAR NHL registry in stable chronic heart failure, NT-proBNP level is mostly influenced by systolic and diastolic function of left ventricle, then atrial fibrillation, anemia, or renal impairment. And we can see the paradox of high body mass index and higher blood pressure beneficial for heart failure patients has been demonstrated. Thank you for your attention.
So again, thank you very much for the presentation. Again, we are perfect in limit, and there is time for questions.
Yes, you had the proportion of women was 19. I think you had a significant selection bias in the series, no?
Well, our sample of patients is from 3 centers where they focus on severe heart failure, and 1/3 of patients was from St. Anne's University Hospital, where we focus on heart transplant, and we have very severe patients, and for the heart transplant there is a limit of age. Maybe a little fluctuable, but limit of age. And when we see the heart failure patients, then the younger are men, the older, little older, are women with dilated cardiomyopathy. So we think this causes the unproportional thing with men and women. So and when you see the large registries of severe chronic heart failure patients, then you can see that men are very much more in these registries than women.
Yeah.
So I find the presentation very nice. You showed a nice regression model, and you showed that there is a significant correlation between uric acid and proBNP, right? And how would you explain this correlation when you already showed that kidney failure is also correlated with that?
Well, we know that when we assess the uric acid, then that in general higher uric acid levels are very associated with worse prognosis, and worse prognosis is very associated with higher NT-proBNP levels. So I think that's the point. So the higher uric acid is in this thing associated with higher anti-pro-BMP level. I don't think there is other correlation in it.
Yes. So thank you very much. Thank you for the answers in the discussion.